Today's lecture is on range of motion and flexibility. Our objectives for this lecture are as follows. We are going to define the difference between range of motion and flexibility, identify properties of connective tissue, identify the deleterious effects of prolonged immobilization. We'll list different forms of range of motion and provide examples for each. We will identify causes of decreased range of motion and methods of restoring range of motion. We'll discuss the neuromuscular influences of the muscle spindle and the GTO on stretching of a muscle. And we'll discuss the stretching and the limitations of lengthening a muscle. And then lastly, we'll identify differences between static and dynamic stretching. So if you're curious of how you should study for an exam, you should look at these objectives and use this as your study guide, because the questions will be taken directly from the objectives and the subsequent matching slides for each objective as we go through the lecture. So you look at the objective, you look at the slide, and you ask yourself, where is the question on this slide? So first off, range of motion. Flexibility is a musculotendinous unit's ability to elongate with the application of a stretching force, whereas range of motion is the amount of mobility of a joint. It is determined by soft tissue and bony structures in the area. So we have somebody with a large calf muscle and a large hamstring muscle is going to have limited knee flexion, compared to somebody that may have very skinny calves and thighs may have a great deal of range of motion at their knee for knee flexion. Can also be affected by the ligaments, by the joint capsule. So some people may have a loose capsule and have a lot of range of motion. Somebody maybe has a tighter capsule, a thicker capsule, and has a thicker joint and is less range of motion. Our range of motion is affected by our skin, especially if the skin has a scar from a wound, or a scar from a burn in particular, or even from a surgery. And then subcutaneous fat. So somebody that has a large belly may be limited on how well they can bend forward and flex their trunk. And then lastly, nerves. So a nerve has the ability to move and glide as our body moves, as a joint moves, and if that nerve becomes tight and less mobile, think of the elbow and the ulnar nerve. That ulnar nerve can scar down, which will limit or hinder your ability to flex your elbow. So decreased flexibility may hinder your range of motion, but it's not always the primary cause. So you may have somebody that is sitting upright with their legs stretched out on a table in a hurdler stretch position, and you may measure their range of motion at their knee for extension, and they have, let's say, negative 20 degrees of knee extension. So which is the cause? Is range of motion limiting their knee extension, or is it a flexibility issue at the hamstring muscles? So then you take that same individual and lay them flat, so now the hamstrings are on slack and they're not stretched anymore. And if their knee goes flat, then you know that the range of motion was limited by their flexibility. But if they lay flat and you still measure them passively at negative 20 or lacking 20 degrees of extension, then you know that the hindrance is in the range of motion at the knee joint and not from the flexibility of the hamstrings. Connective tissue provides support for the body and provides framework, composed of different types of cells that form in various combinations, and they vary in types, orientation, and linking of their fibers, which affect their ability to withstand stress. So let's talk about different types of connective tissue. First off, let's talk about collagen. I always think of collagen as the little fibers in fiberglass. If you look at fiberglass closely, there's just little pieces or little fibers embedded in that fiberglass. That's kind of how I think of collagen. It's just those little fibers are laid down all different directions and are just haphazard through the fiberglass. So collagen provides tissue with strength and stiffness. The collagen fibers bind themselves together, and the more binding you have, the greater strength and stability that you have. Then elastin provides structure and extensibility. So elastin, our skin has a lot of elastin. So if you take and you pinch your skin and you pull it away from your body, it'll stretch out, but then as you let go, it'll pop right back to where it was. That's because of the elastin in the skin. So the more elastin you have, the more flexibility you have. So somebody that has a high degree of elastin, maybe they have excessive elastin, is going to be hypermobile. So those are the people that can do all kinds of funky things with their body and move in directions that more normal people can't. Also, with that mobility, high degree of mobility, they have less stability, so they may be at greater risk for injury or like a shoulder dislocation recurrence type of thing. And then ground substance is just a structureless organic gel. It reduces the friction between the collagen and elastin fibers, and it maintains the space between the fibers. So the effects of mobilization on connective tissue. Connective tissue is continually replaced and reorganized, and it tends to shorten. So as we move about our day and we move our body in different ways, then this connective tissue elongates and it gives us a degree of freedom of mobility. But if we just sit on the couch all day, or we sit in front of a computer for 8, 10 to 12 hours a day, and we don't move, then we tend to get tightness in various joints. The other thing that will affect it is if we immobilize a joint. So immobilization will cause a decrease in the daily activity through that joint in a normal way. So soft tissue, the changes are seen even after 1 week of immobilization. You have a decrease in ground substance, and the collagen and fiber arrangement becomes unorganized. And then if you add in edema to the immobilization, you get increased fibrosis, and you also get a greater degree or a lesser degree of tissue mobility. So your tissue mobility goes down, your fibrosis goes up. You also have a decrease of circulation because your demands at the body part are lessened, so you aren't getting as much circulation, not as much movement, which increases your fibrosis. And then whenever you add edema to it, the edema is with injury is more sticky, and it tends to glue or bind down soft tissue structures. All tissue is negatively affected by immobilization, including bone, articular cartilage, muscle, tendon, joint capsule, and fascia. Connective tissue becomes thicker and fibrotic. The length of time will determine if irreparable damage has occurred. So if you immobilize a part for too long, then it's never going to return back to its pre-injured or pre-immobilized state. Muscular atrophy occurs at different rates depending on the muscle. This can occur within days, especially if you're thinking about the quadriceps muscle with a knee injury. You've probably seen people that have very large thighs go into surgery or have a knee injury, and within days that thigh muscle is much smaller. The quadriceps will atrophy at a quick rate. The calf muscle will do that as well. The gastrocnemius, if you have somebody with an ankle fracture that's been in a boot or has been immobilized in a cast, and they take the cast off and you look at them from behind and that calf muscle is just much smaller than the other side. Articular cartilage is very prone to damage with immobilization, and that's really the primary reason that we've gone away from prolonged immobilization, that we've gone more to walking boots. We've gone from just a knee immobilizer to a hinged knee brace, because the articular cartilage will go downhill very fast, and it has a slow metabolism, and it'll return extremely slow and maybe irreparable, and which is going to lead to an early onset of arthritis for these individuals. So irreparable damage in animal models can occur as soon as 7 weeks. So we usually try to keep immobilization limited to ideally less than 4. Rarely do you see a complete immobilization nowadays. Previously, in the 70s and the early 80s with ACL reconstructions. They would cast them after the surgery and wouldn't allow any type of mobility to occur. And what they found was whenever they took the cast off, these individuals couldn't move their knees. They lost their range of motion. They lost their quad. It took years for them to build back up their quad strength. And then long term, we saw these people showing up with early onset of arthritis in their knees. So early motion prevents the buildup of scar tissue, prevents collateral damage to the unaffected tissues, especially we're thinking articular cartilage there. And then if you take immobilization and you add the edema with weight bearing, now you've got big time problems. So that if you have someone such as a tib-fib fracture that had surgery, they're non-weight bearing, and they've got a lot of swelling or a lot of edema, you really got to get those people moving as quickly as you can to ward that off and to get rid of that edema as quickly as we can. So let's talk about different types of range of motion. First is active range of motion, where you're just raising a body part. You're moving through a range of motion volitionally using your muscle. And then we have active assistive range of motion, where the movement occurs with assistance, maybe from the other arm, through a pulley, using a cane, or rolling on a ball. So you have some type of external assistance. So you're not getting just the muscle that's controlling the activity. And then we have passive range of motion, where the joint is moved through range of motion externally with external assistance. This can be manually or through a device. So you see on the left screen there is a CPM. On the right, that's Adrian Peterson with a Flexionator. If you haven't seen one of those, you may look that up. I think he's got a video on YouTube of using the Flexionator. Now, passive range of motion doesn't truly exist except in the condition of an unresponsive patient under anesthesia. If you ever see the term examination under anesthesia, or EUA, on a physician's operative report. So what the physician will do, especially before a knee or shoulder surgery, he will take that joint, examine it, do a Lachman's, do a pivot shift, or with the shoulder will do some stability testing to see what they are under anesthesia, because clinically they may be fairly stable, but as soon as you put them under anesthesia and they cannot resist, now they may show a very different story for the physician. And then lastly, we have resistive range of motion, which we commonly just call strengthening. So what could cause a decrease in range of motion? It can be one or a combination of any of these things. Pain is a big inhibitor, so pain will prevent you from moving through a range, especially if you have pain at a certain point of the range. Your body remembers that and tries to avoid that pain. Edema, or especially a joint effusion, so if you have a big joint effusion at the knee, it's going to prevent the knee from bending or flexing as far as it normally would. Muscle spasm or guarding will limit your range of motion. So you tend to have one of two things happen with muscles. So a muscle will say, if we don't move, we don't hurt. So that's when you have muscle guarding or spasm. That muscle just locks up and it doesn't allow that joint to move. On the other hand, you have muscles that say, if we don't do anything, then we don't hurt, which is the case of the quadriceps. Then those muscles tend to shut down. So you have inactivity will cause a decrease in range of motion. The older you don't use it, you lose it principle. So if you're just sitting at a computer all day playing a video game, and that's all you ever do, then your joints, let's say you sit with very poor posture and with a rounded back and a forward head, and then one day you can't extend or you can't move your neck through a range of motion as you should be able to. It can also be a result of immobilization. Scar tissue can limit range of motion, especially think after a surgical incision or a burn. Burn patients really have to work on regaining the mobility of their tissue, of their skin, to be able to have full range of motion. And you can also have fear or pain avoidance. So you think it may hurt, so you don't move. So let's talk about regaining range of motion. So the best time to influence collagen is during the proliferation and the early remodeling phase. So if you look at this diagram here, you have tissue response on the vertical axis, and then you have time of healing. So you have the inflammatory phase, proliferation, and remodeling phases of wound healing. So you see that the risk of tissue injury, once you enter into that proliferation phase, you have a sharp drop. So the risk of tissue injury is pretty high during the inflammatory phase. So we have to be careful with those folks. But then as they move into the proliferation phase towards the remodeling phase, you see you can start getting more and more aggressive with them. And that's when we have the greatest ability to alter tissue. So we can influence the collagen arrangement during this time without fear of injury or prolonging their recovery. So we have different methods that we can use or employ to regain range of motion. Of course, we can always use our hands, which is our best asset as athletic trainers. We can do passive range of motion. We can do massage, soft tissue massage. We can do scar tissue massage. We can do PNF, type of contract relax type of things. We can do a higher intensity stretch with a high load and a shorter duration. We can also implement a low load, long duration stretch. I use this a lot with knee extension. Whenever after surgery, if somebody's lacking full knee extension, I'll load them up with a light cuff weight, hang them for 5 or 15 minutes to regain that terminal knee extension. And then we saw pictures of the CPM and the flexionator. There's also an extensionator that they make for knee extension. And then we can use static or dynamic splinting. Most importantly is we need to make sure that our athletes are employing some type of home exercise program. So we want to provide them with an exercise prescription. For range of motion, we want more of a higher frequency, a lower intensity. We'll usually incorporate the active assistive type of exercises and possibly get them a device. This home program really relies on patient compliance to be effective. And then we also need to provide a logical progression for our patients. So we wouldn't want to start off with resistive range of motion if they're limited with their passive range of motion. So let's say they can only move their arm or their shoulder from straight down into their body to straight out in front. So we're not going to start them with trying some type of overhead press. Makes no sense if they can't passively access that part of the range of motion overhead. We're not going to start them with an exercise with weights going overhead. So we want to gain that passive range of motion, get them working through it in an active assistive manner, and then advance from that to an active. And then finally, as they become stronger and they have greater quality of movement, then we can move to resistance. So here's an example of a static splint. So this is just an aquaplast. So they're trying to regain elbow extension. So they may have them sleep in this. You can tape it, or you can wrap it with an ACE wrap type of application, and they're just going to wear this over a period of hours. Down at the bottom you have two examples of dynamic splints. These are removable. They use a spring, or as an example on the right, those are rubber bands that provide the resistance, so they're pulling the fingers up into extension. So with a wrist there, this is likely a radial nerve injury in which they've lost the use of the extensors of their fingers and their wrists. So this holds their fingers up in a position and the wrist in a position. They can still activate the flexors and make a fist, but they're unable to unfurl that wrist actively, or that fist actively. So the rubber band resistance just pops their fingers back up into extension. because what would happen over time if they were allowed to stay into that fisted position, their fingers would claw, and their wrist or their finger flexors would over tighten and shorten, and they wouldn't be able to open their wrist. And the one on the right or the left with the knee is using this mainly to regain knee flexion. You can also use it for knee extension. Whoop, went to the wrong one. Here we go. All right, let's talk about stretching now. So the effectiveness of the stretch is dependent upon 1, the amount of collagen and elastin, 2, the force applied, 3, the duration of the stretch, and lastly, the tissue temperature. So the term hysteresis is an important thing to know with stretching. As we stretch repetitively, the stretching heats the tissue, which decreases velocity and increases length. So you see from the diagram at the bottom, your first stretch is applied, is held, and when it is released, it doesn't go back to the starting point on the strain or deformation axis. So the next stretch, you have a new starting point. The stress or the load is able to be increased. And then once that stretch is relaxed, it goes back again to a new starting point, doesn't go back to where it was previously. And with each subsequent stretch, you get greater deformation. So you're able to increase the stress over time, which increases the deformation or the strain over time. Then the Golgi tendon organ, or the GTO, is located in the musculotendinous junction. It is less sensitive to stretch, but more sensitive to contraction. And it will activate an antagonist as a protective mechanism. So if you're applying a stretch too quickly, then you get the muscle spindle, which will fire and contract to prevent injury. If you're applying a stretch slowly, then the GTO will fire to inhibit the contraction of the agonist. And so as you stretch, you can contract the antagonist, which inhibits the agonist. So let's say you're stretching your hamstring muscles, and as you stretch up, the hamstring starts to fight against you because it's thinking this guy's trying to rip me out of here. So if you will have the athlete fire their quadriceps or the antagonist, then it will help to inhibit the agonist or the hamstring that you're trying to stretch. So as you bring them up, fire the quad, which is the antagonist, inhibits the agonist or the hamstring, and allows you to have a greater stretch. Let's talk about stretching and the effectiveness of stretching. The first two researchers here, Halbertsma and Gecken, I guess, they found that hamstring stretching for 2 10-minute stretches per day, 4 times a week, will increase tolerance to stretch, but doesn't change the actual length of the muscle. So again, that's 10 minutes of stretching twice per day for 4 weeks, and it doesn't change the length of the muscle. And Magnuson and his buddies also had similar results. They were only holding the stretch for 45 seconds, 5 of them, twice a day for 20 days. And then Fulp and his companions, they found an increase in apparent extensibility, but not in real extensibility. Now they were holding stretches for 20 minutes, 5 times a day for 4 weeks. I don't know about you, but I am not stretching any part of my body for 20 minutes at a time every day for 4 weeks. So what we're seeing from these studies is stretching doesn't really change the length of the muscle. It doesn't change the extensibility, the true extensibility or the real extensibility. What it's doing is, what we're seeing from these studies is we're seeing a change in the stretch tolerance. So anytime you stretch a muscle, you get that uncomfortable feeling. You stretch your hamstrings, and you stretch far enough and it starts to hurt. It becomes painful. And so what happens is, as you stretch, you're changing the stretch tolerance. You're changing the tolerance of that uncomfortable stretch feeling or stretch sensation. So your body's getting used to that, so now you can go a little farther into that stretch than you were before. So to truly get a change in extensibility, you have to get into this plastic region, this large region from the yield point to the failure point. So you see as you place stress onto a muscle, stretching it, it goes up pretty rapidly. The stress goes up quickly to the yield point, and that's the elastic region that you're going into. So remember, with the elastin, it allows you to go right back to where you were before. So as you stretch into that point, if you just take it a little farther on the stress, but you go farther in the strain, then eventually you get to a failure point where you're going to, the failure point is the cross between the ultimate strain and the ultimate stress. At that point, you're going to get tissue failure, and that's going to result in damage to the tissue. You're either going to tear the muscle or tear the fascia. Something's going to be torn, and your athlete's not going to be happy with you at all. So we're really not able to get into this plastic region, typically because pain stops us at that yield point. And so what happens is with the repetitive stretching, you're able to change that yield point a little bit, but you're never really able to work into that plastic region where you have true gains into real extensibility. So let's talk about the difference between static and dynamic stretching. So there's no real evidence that static stretching before activity will reduce muscle injury rates. There have been a number of studies that really haven't shown that, especially with runners. A study here by Kay and Blazevich found that in a systematic review, 55% of their articles stretching for greater than 60 seconds significantly reduced strength, power, or speed. A stretch less than 45 seconds does not. So let's make sure we're keeping our stretches kind of in that 20 to 30 to 45 second range. So we don't want to hold those stretches for a prolonged period of time and inhibit those muscles and reduce the strength, power, or speed. So Aguiar and his buddies there compared a dynamic warm-up with a static stretching protocol and their effects on performance. So the results showed increased hamstring flexibility and eccentric quadriceps peak torque with a dynamic warm-up, but no difference for vertical height, power, concentric, eccentric, hamstring peak torque, or ham-quad ratio. So they did not do static stretching for the hamstring flexibility, but they did a dynamic warm-up. And so they actually improved the flexibility of the hamstring. So a dynamic warm-up consists of dynamic stretching, agility, plyometrics, and specific motor pattern movements. So this helps to increase the core temperature, the muscle temperature, and also enhances the nervous system for function. So it kind of wakes up the body, prepares the body for activity. And that's our lecture for today. And I'll see you in the classroom and in lab. Hope you enjoyed it. Come to class with any questions that you may have.